The Heart Demystified. Smarter Heart University and Dr. Scott on AM 970, The Apple.
Welcome back to your Smarter Heart University. We did get cut off of that first segment, going out to the second, and I did want to mention our phone number, 866-970-9622. That's 866-970-9622. For anybody out there who has a question, we'd love to be able to answer at any time during this show. So the answer to the pop quiz, persons older than 60 who are considered to have only low or moderate risk for heart disease, do they have 10%, 20%, or 30% abnormal ABI? These are people without symptoms. They just have some low risk. Believe it or not, folks, 10% of the patients older than 60 will have an abnormal ABI, but would otherwise be considered low or intermediate risk for a heart attack or a stroke. Therefore, they wouldn't be treated aggressively. So when one actually considers it, any method to improve early identification of a higher risk for a cardiac event should be performed regularly, right?
I agree.
Yeah, I mean, that's change of heart cardiology. That's our motto. Get to it before it gets to you. In 2005, however, the American College of Cardiology, the American Heart Association, as they always do, put forth a joint task force of guidelines and recommendations for the management of PAD. Ironically enough, there was an analysis of that 5 years later that said these recommendations and guidelines still are not being followed, adhered to, or not being made aware of at this point. The important aspects we're going to tell you about included obvious therapeutic lifestyle changes of stopping smoking, of changing your diet, getting control of your blood pressure and sugar, and, of course, exercise. We're going to talk about that on Section 4. They specify that only after these approaches, combined with medical therapy and pharmacologic therapy, again, we'll talk about this, which we're going to cover, if the pain in the lower extremities is disabling or it's limiting, then physicians should consider what you do, intervention or the vascular surgery. And the reason is, their specifications, their reasoning is that the majority of patients, about 70-80%, will have no deterioration. About only 10 to 20% will get worse total, and only 1 to 2% will develop that critical disease, with only less than 4% requiring amputation. So these are pretty low numbers, and that's their findings from analysis from a lot of studies. But remember, folks, if you have PAD, don't worry about your legs, worry about your heart. Dr. Bob said it a number of times. I want to say it too. Now, how do we treat PAD medically is very, very important. So think about it this way. It is well established that even with mild plaque or blockages that we find by CAT scans, which is a segue to next week, or angiograms of the coronary anatomy, those are catheterizations, that your risk for a heart attack or dying is much higher, and we treat that normally with statin medications, because it's somewhat mandatory at this point to reduce this risk. Of course, lifestyle modifications are also concomitantly being recommended. We always talk about that. So even if mild plaque or blockages in the carotid arteries are found, okay, and I just came back from a conference, the same holds true for a higher incidence of heart disease. So it's, in a sense, the carotid arteries are a window into your heart as well. Here's how I put it with our patients in the office almost every day. If I treat you today as if you've already had a heart attack, you won't get one in the future. Enough said, right?
Yeah, completely.
Okay. So the same thing should hold true for PAD. Many believe studies have justified that it is a coronary equivalent. Just like diabetes was crowned this a coronary equivalent back in 2001 by a major panel. We break down medical therapy for PAD this way. High blood pressure. Of course, the best blood pressure for everyone should be at least less than 140 on the top systolic and less than 90 on the bottom, and less than 130 on the top and less than 80 on the bottom for persons with diabetes and chronic kidney disease. But one special consideration for the PAD patient comes from a large trial several years ago that showed that patients with vascular disease as well as diabetes, even if they haven't had anything happen yet, benefit specifically from a class called ACE inhibitors. And this actually produced a reduction in events such as a heart attack and a stroke. They cause, though, a hacking, dry, annoying cough in about at least 15% of people. Recently, a trial that just came out about a month ago suggested a very significant higher incidence. So an alternative in the same field, in the same class, kissing cousins, so to speak, are angiotensin receptor blockers. They act on the same pathway, and they have less than a 1% chance of that side effect. Of special note about blood pressure pills, many years ago, it was said that beta blockers were thought to worsen PAD symptoms. This is recently found to be untrue, and they're not contraindicated in PAD patients with high blood pressure. Cholesterol, next subject. And I'm going to only be real brief about this. As I just stated, PAD should be considered a coronary equivalent, plaque in the legs, plaque in the heart, plaque in the carotids, and as such, statins should be considered the mainstay of PAD therapy, with a goal of your bad or LDL cholesterol less than 100 for everybody, and about less than 70, and we try to shoot for that for all our patients, but in high-risk patients, in those individuals considered to be high risk, should be less than 70 in your bad cholesterol. Diabetes, while no clinical trial has shown that controlling your sugar with PAD reduces events, it's advised to get your hemoglobin A1C, which is a measure of sugar carried on your red blood cells, looking at an average daily sugar over a 3-month period, to about or less than 7%. Normal is considered to be less than 6%, but recent reports have shown that there's no benefit or even a worse risk with very aggressive lowering of blood sugar in type 2 adult onset diabetics. Now, blood thinners, because that's a big issue. This is a very debated and studied area. Your platelets, because your platelets are really central to developing plaque and clot in your arteries. Aspirin's the most well-known and established antiplatelet agent, but a recent analysis, and a somewhat meta-analysis, a somewhat dirty word to those of us here at Smarter Heart University, revealed that aspirin did not reduce, were you surprised about this? Aspirin did not reduce the risk of a heart attack and stroke in patients with PAD. Were you surprised?
Yeah, a little bit.
That being said, aspirin is the cornerstone of PAD therapy between 75 and 325 milligrams daily. Clopidogrel or Plavix is what I consider to be super aspirin. That's what I tell our patients. It's slightly superior. It works on platelets in a similar fashion down the pathway a little bit, in a more complete fashion. It's considered slightly superior to aspirin, and in one trial, it was better at stroke and heart attack and patients that already had PAD, a stroke and a heart attack. It does have a higher risk of bleeding, especially in the stomach and bruising, so therefore aspirin should be considered to be used first. And of course, as many of you that know out there, if you've had a heart attack or a coronary syndrome or a stent, we combine aspirin and Plavix together for at least a year after we fix a coronary blockage to prevent a clot from forming inside your stent. But a large trial showed that taking the two together to prevent cardiac events in those who have not yet experienced any of this did not benefit, or again made things worse. Therefore, one or the other is currently considered and indicated to be used for PAD. Basically, if you have an aspirin allergy, clopidogrel or Plavix should be the drug to use. Lastly, on blood thinners, warfarin or Coumadin, which thins red blood cells in certain conditions like stroke, has no place in PAD treatment. Finally, on a medical treatment front, I bring up a very interesting medical tip. While supplementation with folic acid and vitamins B6 and B12 to lower higher homocysteine levels. So this is the integrative medicine part of me. We talked about this on vitamins in the heart. This doesn't help reduce cardiac events. A 12-year trial suggested this approach, giving folic acid, B6, and B12 on 50,000 men decreased PAD risk by 21%. So this led to speculation that daily intake with omega-3 fatty acids, the fish oil, and folic acid and B vitamins may increase your walking distance may make you pain-free and improve the risk factors in peripheral vascular disease patients. Now, as we've stated on our Vitamins and Heart show and over the past 2 weeks on the complementary and alternative medication shows, further clinical trials are going to need to be undertaken for this type of approach to be validated. That's a lot on the medical front, but what's your take?
My take on the medical treatment is what are we treating? Most of what we're treating is the heart attack that goes along with this, the cardiovascular consequences, and so we're trying to prevent the blockages in the leg from getting worse, but we're also trying to prevent that heart attack. And patients always ask when I put on the Plavix, is this going to take the blockage away? No, it's not going to take the blockage away. This is going to try and prevent the heart attack that goes along with it. So we're as a cardiologist, we're always trying to focus on what is the cardiovascular effects, which is the heart attack and stroke, but
right,
as well as the lifestyle component of making sure that your legs don't hurt when you walk and restoring good blood flow. So, you know, it's a two-pronged approach at that point. And your physician should be doing both. You shouldn't be just fixing a blockage and saying you're done, or you shouldn't be just saying I'm going to put you on medications to make sure you don't have a heart attack. You should be dealing with both the lifestyle, it hurts when I walk, as well as the heart attack.
Well, a lot of times I get the ABI. I do the ABI, you get it, and then you call them and put them right on the aspirin right then and there. Exactly. Going out to break, pop quiz number 3 for Dr. Kaiser and everybody else out there. Gloomy and socially inhibited people with PAD have a 2 times, 3 times, or 4 times more likelihood to have a higher mortality risk.
Wow. 4 times.
Okay, we'll be right back on AM.
More Dr. Scott and Smarter Heart University is on the way on AM 970, The Apple.